There is a sentence that millions of people hear every year in a doctor's office. A short sentence, spoken calmly and with confidence. And that sentence changes everything. I recommend surgery. And at that moment, what do most people do? They nod. They sign the paperwork. They trust. Because they have always been taught that the doctor knows what is best for them. Because the doctor went to medical school. Because the hospital has the equipment. Because the forms are already ready. But what nobody tells them clearly is that this recommendation is not an absolute certainty. It is the beginning of a conversation. You have the right to have that conversation. You even have a duty to have it. For yourself and for the people who love you. Today, I am going to tell you the truth about 5 operations that carry serious risks that are too often downplayed, especially for people over 60. What you are about to hear is not meant to frighten you. It is not meant to push you into refusing medical care. It is meant to give you something precious that too many patients have never received: knowledge. Because an informed patient is a patient who actively participates in their own healing. And that changes absolutely everything. First, let me share something that medicine took far too long to acknowledge. Imagine 2 cars. The first one is brand new, just off the assembly line. The second one has 200,000 miles on it. It still runs well. It has been well maintained, but its parts have aged. Now put both of those cars through the exact same extreme stress test. Do you expect the same results? Of course not. Nobody would. And yet, for decades, medicine treated a 70-year-old body exactly the same as a 40-year-old body. Same surgical protocols, same recovery expectations, same timelines. That is starting to change, but not fast enough and not clearly enough for the patients who need it most. Here is what actually happens inside an aging body under general anesthesia. The heart has to work harder. The lungs take longer to clear the anesthetic agents. The kidneys slow down in processing medications. And the brain, this is the one that surprises people the most, can become temporarily disoriented in ways that can last weeks, sometimes entire months. Doctors have a name for this: postoperative cognitive dysfunction. In plain language, this means that some older patients come out of an operation with a more fragile memory, difficulty concentrating, or a state of confusion that can deeply worry the entire family. In patients over 70, this happens far more often than is publicly acknowledged. Now, this is fundamental. Age alone is not a reason to refuse surgery. I have operated on people in their 80s who recovered faster than some people in their 50s. Age is just a number. But frailty is not just a number. Frailty is a precise medical term. It describes the point at which the body's reserves have fallen below a critical threshold. Roughly 40% of people over 75 show signs of medical frailty. That number rises to nearly 60% beyond the age of 85. So the real question to ask before any major surgery is not, can this person survive the operation? It is, can this person survive the recovery? Those are deeply different things, and that distinction is going to matter enormously in everything I am about to share with you. The first operation I want to talk about is open heart surgery in frail patients. Coronary artery bypass grafting is one of the most common major surgeries performed on older adults. The idea is straightforward. If your arteries are blocked, surgeons reroute the blood flow. For the right patient, it works beautifully. But here is what the brochure never shows you. This surgery requires stopping the heart completely. A machine takes over the work of the heart and lungs for the entire duration of the operation. For a 60-year-old in good physical shape, that is manageable. For a 78-year-old with kidney disease, mild diabetes, and early signs of cognitive decline, that machine represents a simultaneous assault on every organ in the body. Studies show that in frail elderly patients, the risk of major complications is between 30 and 40%. Stroke, kidney failure, prolonged confusion, extended time on a mechanical ventilator. and something that stops people cold when they hear it. Up to 15% of high-risk elderly patients do not survive the first 30 days following the operation. So what is the alternative? Today, one exists. It is called TAVI, transcatheter aortic valve implantation, a catheter-based procedure that never requires opening the chest or stopping the heart. Less dramatic than traditional surgery, and infinitely kinder to a body that needs kindness, not another battle. The question to ask your surgeon is simple. Am I a candidate for a less invasive approach? That one question alone can change everything. The second operation is aggressive spinal surgery. Back pain after 60 is almost universal, and the solution offered more and more often is spinal fusion. Screws, rods, and other hardware are inserted along the spine. A landmark study published in the journal Spine found that in patients over 65, complex spinal fusion had a complication rate exceeding 40%. Blood clots, infections, hardware failure. The vertebrae next to the fusion often begin to break down because the mechanics of the spine have been permanently altered. One section becomes rigid, and the rest of the back pays the price. What concerns me most is this. For many older patients, aggressive surgery provides no better long-term pain relief than serious physical therapy and targeted injections. No better, but it comes with dramatically higher risks. The third operation is major cancer resection. This is the hardest one to talk about. When someone hears the word cancer, the instinct is immediate and powerful. Cut it out. Remove it. Get rid of it. The goal of treatment is not simply to remove the tumor. The goal is to give the patient more good years of life. And sometimes, but not always, major surgery in a frail, elderly patient does exactly the opposite. Pancreatic cancer surgery, for example, is one of the most complex operations in all of medicine. It takes between 6 and 10 hours. In younger, healthy patients, it can be life-saving. In an 80-year-old with heart disease and reduced kidney function, the surgery may technically succeed. The tumor is gone, and the patient still passes away a few weeks later from surgical complications, not from the cancer, from the operation itself. A landmark study from the American College of Surgeons found that nearly 1 in 5 elderly cancer patients who underwent major resection experienced failure to rescue, meaning a complication arose that the weakened body could not survive. Ask your oncologist directly this question. If we do not operate, what does watchful waiting, radiation, or targeted therapy look like for someone my age and health profile? That question opens a door many patients never even knew existed. The fourth operation is elective joint replacement in seriously ill patients. Hip and knee replacements are among the most successful surgeries ever developed. I say that without reservation. For the right patient, a new hip genuinely transforms quality of life. People go from barely walking to playing with their grandchildren. It is remarkable, and it is true. But in patients over 75 carrying multiple serious conditions, the risk of blood clots is substantially higher. A clot forming in the legs can travel to the lungs and become a potentially fatal pulmonary embolism. Add the risk of post-operative pneumonia from prolonged immobility. Add hospital-acquired infections. The picture becomes far more complex than what is often presented in consultations. The question is not, should I ever consider a joint replacement? The question is my body in the best possible condition right now? Optimizing blood pressure, blood sugar, and cardiovascular health before surgery can reduce complication rates dramatically. Has your doctor ever spoken to you about prehabilitation before a scheduled surgery? Prehabilitation means a structured program of physical and medical preparation in the weeks leading up to the operation. Most people have never heard that word. They absolutely should. Prehabilitation can make surgery safer and recovery faster. The fifth situation is emergency abdominal surgery. This one is different from the 4 others. You do not choose it. A perforated bowel, a ruptured appendix, internal bleeding. These situations do not wait for a calm conversation in a doctor's office. But here is why it belongs on this list. Knowing the risks in advance, before an emergency happens, changes how families make decisions in those terrifying moments. In patients over 75, mortality can reach 30 to 50% in the most severe cases. Not because surgeons lack skill, but because an aging body under sudden trauma is fighting on too many fronts at once. The inflammatory response that a younger body controls within days can spiral in an older body into a progressive failure of multiple organs simultaneously. 2 concrete things to take away. First, never ignore persistent abdominal symptoms. Pain that lingers, unusual bloating, or changes in bowel habits in someone over 60 deserve prompt medical attention. Catching problems early prevents emergencies. That simple habit can change everything. Second, have the conversation with your family now, not in a hospital corridor at midnight, now at home, around a table. What are your wishes if emergency surgery is the only option? What quality of life matters to you? This is not a morbid conversation. It is one of the most loving things you can do for the people who love you and who might one day have to decide on your behalf. Before any major surgery, planned or recommended, ask 4 questions. Write them down if you can. First question: what happens if I do not have this surgery? A good surgeon will give you an honest answer. If nothing urgent changes over the next 6 months, you have time. Time to think. Time to get a second medical opinion. Second question: is there a less invasive alternative? Medicine has evolved considerably over the past 15 years. Options that did not exist a decade ago are now available in most major hospitals. Third question: what does recovery realistically look like for someone my age and my specific health profile? Not for the average patient, for you, your heart, your kidneys, your current medications, your situation at home. The answer needs to be concrete and personal. Fourth question, the one almost nobody asks: what is your personal complication rate for this procedure in patients over 70? Surgeons track these statistics, and they know their numbers. An honest, confident surgeon will answer without hesitation. If the surgeon seems uncomfortable with the question, that itself is information worth having. Let me tell you about a patient. I will call him Gerald. Gerald was 71 years old, a retired engineer. 3 different surgeons had recommended open heart surgery for a blocked coronary artery. 3 opinions, the same answer every time. Gerald was not afraid of the surgery itself. He was afraid of losing himself. He had watched his wife go through a major operation 2 years earlier and never quite come out the same. He told me that she went into the operating room as his wife, and she came out as someone he had to take care of. That story has stayed with me ever since. When I reviewed his full profile, his kidney function, his frailty score, his cognitive baseline, I sat down with him for 40 minutes, not 15. Surgery was an option, but an aggressive medication protocol combined with cardiac rehabilitation was another. The data for his specific profile showed comparable 5-year outcomes between the 2 approaches. He chose the non-surgical path. That was 4 years ago. Here is the most important thing I will say today. A surgical recommendation is not a verdict. It is the beginning of a conversation. You are not a passive recipient of medical decisions. You are an active participant in your own care. The moment you walk into a surgeon's office, you have the right to ask every hard question, to request every alternative, and to take every day you need. The surgeon holds the scalpel, and you hold the choice. That choice, made with full information and clear eyes, is the most powerful tool in medicine. More powerful than any operation I have ever performed. Take care of yourselves. Stay curious about your own health. Ask the hard questions. Seek out the alternatives. Get a second opinion, and if necessary, a third. You deserve every bit of it. Everything I have shared today is general medical information, based on published research and clinical experience in the field. Every personal situation is unique. Before making any decision about surgery or treatment, have a full and honest conversation with your own doctor or specialist. They know your history. They know your body. And that conversation, informed, direct, and unhurried, is exactly where good medicine begins.